We are pleased to welcome all delegates on behalf of ISA Miraj Sangli branch, GMC Miraj, and Bharati Vidyapeeth Deemed University Medical College Sangli. We assure that everyone will enjoy, learn, and have a good time in this CME. The world is full of diamonds and gems, and we have some here with us today. We have excellent teachers and experts present here today to help us understand, improve our practice, and solve our doubts. So without any further delay, let us start with our first session. I would like to mention here that our first 3 sessions are dedicated in the memory of respected Dr. Maskar sir. I request Dr. Ashok Deshpande sir to please say a few words.
Good morning, everybody. We are starting our session today. In the last 20 years, we have lost 4 of our colleagues. One was Dr. Maskar, second was Dr. Phansobkar, third was Dr. Gokhale, and fourth was Jayanti Kulkarni. So last day's workshop, we are dedicated to Jayanti Kulkarni. Today, we are dedicating this session to Dr. Maskar. Dr. Maskar was here from 1958 in Miraj. He was practicing. And he passed DA from London, and then he was in Aden for 16 years. Then he came to Miraj over here. He practiced over here. He was the first practitioner of the Miraj city, qualified one. And then later on, everybody came here, and he served this whole area for odd 43 years again. And we have lost him, and so this session is dedicated to Dr. Maskar. Thank you.
Session is Difficult Airway in Obstetric Patients by Dr. Hemant Shinde sir. For this session, I would like to welcome our chairman Dr. Dilip Paranspe sir and co-chairman Dr. Avinash Bhosle sir on the stage. Dr. Dilip Paranspe sir did his MD from KM Hospital in 1978 and has been practicing as senior freelancer consultant in Kolhapur for over 40 years now. He has worked as treasurer, vice president and president in MSICA. Co-chairman Dr. Avinash Bhosle sir has been working as freelancer since last 26 years. He has served as past vice president and GC member of MSCICA, founder secretary and past president of ISA Satara. He has a record of 14 awards in state and national level in presidentship of ISA. Not to forget President Appreciation Award from IMA State for Best President of IMA 2011. He is also a sport enthusiast and he has contributed free services in many surgical camps. Thank you, sir. I now request the chairman, sir, to please introduce our speaker for the session, Dr. Hemant Shinde, sir.
Hello, good morning, everyone. It gives me immense pleasure to welcome you all. Let me introduce Dr. Hemant Shinde. He is a consultant anesthesiologist at various hospitals in Mumbai. He did his MD/DA from Mumbai University. He is the present editor of MISA News. He is secretary of ISA Mumbai between 2013 to 2016. Organizing secretary VAD 2013 and VAD 2015. He loves teaching anesthesia and his new love is cycling. Now the topic is very interesting. To me, anesthesia, airway and accidents, they are synonymous. Even though we feel we are masters as far as airway is concerned, there is a wonderful saying in Sanskrit, Ati Parichayat Avadnya. Because we are so very familiar handling the airway, invariably we do many mistakes. And difficult airway, that too in obstetric patient, must be still more difficult since the respiratory reserve is already low. And to add icing on the cake, we have got a speaker like Hemant Shinde to discuss the topic. So I'm very sure the topic and the discussion is going to be very interesting. Dr. Hemant, please.
Thank you. Thank you, sir, for the kind words. And good morning. Good morning, everybody. My first visit to Sangli, even though my mother hails from this district. And the topic today is, of course, difficult airway in obstetrics, risk assessment, prophylaxis, and management. The best thing is not to let this happen. So a large part will be spoken about what are the risks, how do you assess them, prophylaxis mainly. Management is only a small part. Any idea where is the timer? Okay, then you will tell me last 5 minutes, then I will have a fair bit of idea, because otherwise it just keeps going on, and 9:04 I'm starting. It's 30 minutes. Yeah. I come from city of Mumbai, the city of dreams, the city who doesn't sleep, and this is the area where I cycle. That's why I said my new love is cycling. Yes, it keeps me fit. Explore the city which I have never seen, such a beautiful city. But we are here to discuss today about what are we going to discuss. I'll tell you some definitions, initial part, and we'll try to get acquainted with the topic. Why the incidence of difficult intubation is increasing. We'll see what are the causes about it. Is there any role of obesity? Then we'll of course assess the difficult airway. We also are going to talk some about gadgets, how they have changed our lives, like your video laryngoscope or supraglottic airway devices, the cart which I'll show you. If you don't have it, please make it. At least that one take-home message you must have. Thrive is having a great role in difficult airways. Then, of course, we'll see the management, that is the algorithms for anticipated difficult airway in obstetrics, the unanticipated airway. The most important, is extubation important? Fine, everybody, the large part is going to be about how to intubate. But does anyone know how to extubate such patients? Is it important? We will see the evidence. And lastly, of course, we'll conclude and we'll have some take-home messages. To start with, what is a difficult airway? I told you I'll tell you some definitions. So whenever it's a little difficult to provide adequate oxygenation, difficult ventilation, and you are unable to prevent aspiration, which may lead to hypoxia, that is a case of difficult airway. Then, since it has got two components, you are unable to either intubate and you are unable to either ventilate. So what is an impossible mask ventilation? When you do all these things and you still can't ventilate a patient, that is an impossible mask ventilation. What is it? That you cannot provide positive pressure ventilation despite repositioning of the neck, anterior lift of the jaw. You are using oral airway, you have tried nasal airway, you've called for help, you have tried two-hand ventilation. That all is not possible, two persons rather. So that is an impossible mask ventilation. Then came the supraglottic airways. So what is a difficult LMA ventilation? After 3 attempts, if you can't deliver 7 ml per kg tidal volume to the patient at a leak pressure of more than 15 to 20 millimeters or centimeters of water, that is an impossible LMA ventilation or difficult. And finally, of course, how do you define difficult intubation? Despite doing all these things like change of position, use of blades, use of different person. I mean, I am doing an intubation and I end up calling someone far too senior and more experienced than even me to come to the OT and try. That also is not possible. And then, of course, posterior cephalad displacement of the larynx by external pressure, all has gone in vain. Then we say it's a we define it as difficult intubation. Now, this paper came way back in 2007, 15 years ago, and it says, have we invited this problem onto ourselves? Is it a self-fulfilling prophecy? In a partly it is true, because if you ask me, when was the last general anesthesia cesarean section I did, I don't remember. Pre-COVID, I'm sure I must have done. 3 years at least I have not done a GA section. And then you ask me the next question, when did the last cesarean section you did? 2 days ago. So all our cesareans are going under regional anesthesia. Am I right? Has anyone done GA section recently? No. See, that is what. That's why he says we've invited this trouble on us. Why? The incidence is around 1 in 400. Incidence is likely to increase. Why? Because all of us are giving regionals. If the teacher doesn't know how to do a GA section, how am I going to teach my student how to intubate a GA section? That is what he's saying. You have invited this problem onto yourself. And on top of it, the obesity is increasing. Even though we fall 6th in the list of obesity, because of sheer population explosion India has. Modi ji keeps on saying, 100 crore, no, now it is I think 140 crores. So if 140 crores ka 6% are obese, you imagine the amount of obese we have it in India. My calculation tells me that's about 84 crores. 840 crores. No, 140 कोटीच्या 6%. So 8.4 crores is how much? 4 Mumbai cities. 4 Mumbai cities we have in obese population. We are world number 2 as far as numbers are concerned. And we are only next to the mighty United States of America. So we've invited this trouble by wrong diet. Ladies are getting pregnant at a later age, IVF, obesity, as such as infertility. We'll discuss all that. So this is a problem which we have invited upon ourselves. Busy slide, don't read too much, but it says whatever said to be said in red. That is failed tracheal intubation during OPS, general anesthesia. 1 death per 90 failed intubation. That is serious business now. Now we are getting 1 person dying out of 90, mostly because of aspiration or esophageal intubation leading to hypoxia. And whenever we do FONA, that is front of neck axis, that is either a tracheostomy or a cricothyrotomy, the study says by the time the patient is already gone. So we are entering FONA very late. So take home message, first don't let it happen, but God forbid it happens, go for the FONA ASAP. Don't think too much, should I do, should I call somebody? No, call somebody and get it done if you can't do it yourself. What's the maternal mortality and morbidity? This study came in 2000 and only 2-year study, they saw the trends and they wanted to know what goes on. This is British Journal of Anesthesia. Leading cause is, of course, airway complications, and GA has more mortality. How common it is? How common? Now, the different countries have different papers, different statistics, but by and large, most of the literature says it's about 8 times more common than your normal surgical power. 8 times, and then there is another study which says it's about 3 times more common. So the real incidence must be between 3 and 8. Whether it is 3 or 8, but it is more. So try and understand 8 times more common, and it normally happens in emergency cesarean sections. So imagine a scenario where you've called upon at 2 a.m. in a roadside nursing home where you are frequenting many times. Patient is eaten, because in our country, when you go to a hospital, you are supposed to go eat after food, because you don't know when the next food is going to be. Whether you are pregnant or you are not pregnant, that is a universal truth. Patient comes at the middle of the fetal distress, surgeon says patient is full stomach, you go, you see 140 kilo patient. Middle of the night, no ward boy, who gives position, God only knows, surgeon waiting with the scalpel, fetal distress, your spinal fails. Is it impossible? No. This has very much happened. It has happened with me. It has happened with, and it will happen with me again. And it's going to happen with you also. So emergency cesarean sections is the biggest headache. On top of it, obesity and high-risk anesthesia. So is obesity significant? Yes. What does the literature says? We'll see. 15 cases died. This is a classic paper. If you get to read it, it's on Google. Please do read it. In 1972 to 84, they did this study, and then Jill Meyer, she's an anesthesiologist, obstetric anesthesiologist from United States. She followed the study in Michigan from 85 to 2003. 15 years windows, they were searching how many patients were dying. This duration, 15 died, 12 were obese, and mind you, 10 cases died in emergency surgery while intubating or aspiration, or the tube went into esophagus, for whatever it is. So obesity is significant. Okay, we'll see what happened the next. This is that Jill Meyer study I was telling you. 85 to 2003, the numbers came down. 8 anesthesia-related deaths, 6 were obese. So the obesity is constant. But this time, the timing of death changed. Then the patients were dying while intubating. Here patients were dying during extubation because of hypoventilation and obstruction. Maybe our protocols have changed, maybe our gadgets have changed, so we are better off intubating, but we are very sad in extubation. We will see almost at the last slide when I say how sad we are. Okay? So this is what it is. So now you don't have too much focus on your intubation, but also have some amount of focus on your extubation also. But why? Why still obese are at high risk? Why? Like I was saying, obesity problem starts right from your infertility. They are infertility, so you will be called for those ovum pickups and their diagnostic hysteroscopies, diagnostic laparoscopies, myomectomies, ovarian cystectomies. So that is in the pre-conceive. Then, of course, they will conceive and they'll end up with you. So, os tightening is another thing they will be called upon. Finally, they go in labor, you will be called on for a labor analgesia, and finally she lands up in a cesarean section, so you will be asked to convert that epidural into GA or spinal or whatever it is. So obstetric interventions are extremely common in these obese patients. And chances of your spinal failing are extremely common because I told you it's a difficult positioning, difficult anatomy. The woman is already obese, on top of it she has put on weight. Difficult positioning. So and fetal distress, surgeon ready with a scalpel, he wants immediate action. So you end up giving GA. So that's it. But they'll still we persist. Why? Why they're still at increased risk? And it is because the positioning is different, the intubations are different, the ventilation is difficult. Somebody is giving cricoid pressure. We've been told all in our residency, every pregnant patient you have to consider as a full stomach patient. So somebody has to give cricoid pressure. The moment they start giving cricoid pressure, the neck becomes like this. So the other hand, so someone who's trained to give cricoid pressure must give cricoid pressure, otherwise your intubation becomes difficult. So inappropriately put cricoid pressure adds to your problems rather than saving the problem. So there is no harm. You ask the person to take off the hand and put in the tube. Macromastia, yes, the enlargement of breast is very common in these obese patients, so they are at risk. You need smaller handles, otherwise the breasts come in your way while intubating. Physiologically difficult airway, I mean, Dr. Divatia, you must have heard speaking on this topic n number of times. Every patient, pregnant patient, is a physiologically difficult airway, not only anatomically difficult, by what we mean by physiologically is their FRC is reduced, their oxygen saturation starts dropping very fast because they are consuming more oxygen. This happens in a normal pregnant patient. On top of it, you have an obese pregnant patient, and there is another life inside. So the oxygen need has gone up dramatically. So these patients drop their sats within no time, and you are anxious all the time. The moment you see a 100+ kilo patient, I did one 137 kilo patient 2 days back. She was at 5:30 in the evening, but with an excellent surgeon and in a tertiary care hospital, so I was not worried at all. She was a gestational diabetic, polyhydramnios, 4 kilo baby with PIH. Single shot spinal, Whitaker 25, done and over, 2.1 cc sensor cane with fentanyl. End of the story. I am standing quietly like a mouse in the OT because I don't want trouble. God forbid if I have to. I have video laryngoscope and the works in that hospital, but I am scared. So operator anxiety, even 30-year-old practitioner is getting worried despite being in a tertiary care institute with all the help around. You can imagine in the middle of the night, the example which I was giving you, what can happen to an anxious anesthesiologist. These guys do amazing studies. They opened their cases where cases were out of court settlement, and they wanted to learn why this data always has to come from United States of America and Europe. I don't understand. The closed claims means the anesthetist has been, or the hospital has accepted the problem was with us, and then they opened it to learn what mistakes we did, and see what they found. In most of the cases, the management was absolutely third class. Substandard management, esophageal intubations in United States of America with all ETCO2s and the gadgetry around, inadequate ventilation, esophageal intubation, and difficult intubation. So they were practically saying, our guys killed these patients, and they accepted it, and they paid also. Incidence of difficult intubation is around 7.9, say 8%, and this slide says, Sachin Khetrapal, I think, no, this is DA Rock. More than 3 times the incidence witnessed in the non-obstetric population, right? So that guy said 8 times, this guy says 3 times. So somewhere in between we have incidence, okay? This is Sachin Khetrapal, I was telling you. 23,000 cases he saw, and he's found only 0.37 cases. % of cases were difficult or impossible. Another says 16%. My point here is, it may be whatever it is, variable from less than 1% to 16%, but you have to understand these patients are at extremely high risk, so you got to be a little careful. Are there any risk factors where we can predict what is going to happen? Let's find out. So this happens in every pregnant woman, whether she is obese or not obese, whatever it is. This happens in everybody. And what is it? Airway edema. The uterus, that is pelvic organ, becomes abdominal organ, pushes the diaphragm up, FRC goes down. Increased oxygen consumption, yes, it happens in every patient. Weight gain, enlarged breast, happen in every patient. Full dentition is a possibility that the teeth may be ahead. And the sphincter, esophageal, lower esophageal sphincter tone goes away, and gastric emptying during labor also decreases. So this happens in every. On top of it, now see what individual factors can have. Now these are individual variations. Now a lady may have bull neck, large breast, large epiglottis, large tongue, difficult neck movements, all sorts of problems. And on top of it, now you will have to add certain syndromes, like Downs, Klippel-Feil, goiter and other infections, Ludwig's angina, preeclampsia. So with all these additions of 1 plus 1 plus 1 plus 1, we are going to have lots of problems. That's why your airway assessment has to be good. But what is the reality? The paper shows 1,200 patients. Only 51% we could identify that this intubation is going to be difficult. In other words, 49% patients. So that's almost 50-50. One you could identify, one you could not. That's the whole problem. That's why I like how Vidya Balan in that movie, I forgot the name, but I've seen it. What are movies? Entertainment, entertainment, entertainment. So I always say, what is difficult airway in obstetrics? Airway assessment, airway assessment, airway assessment. That is what you should do to prevent it, right? Lemon, that is very common. You got to do it. You can't miss it. Look, evaluate. We know all these 3-3-2 rules. Malampatti 1, 2, 3, 4, everybody knows. But do we do it? That is the question. If we are missing out 50% of our patients, that means we are not doing it. Or even if we are doing it wrongly. One take-home message. This comes from the god of obstetrics, Bhavani Shankar Kodali sir. He says, you may be called to give an epidural. She is early morning, and in the morning you see her, she's hardly 2 centimeters. You go, you have do your PSC, and then you go to do your list. You say, I'll come little later and I'll give you an epidural. 7 centimeters down or 5 hours down in labor, her airway edema will change. So labor is a dynamic process. So your PSC also has to be dynamic. You can't be relying on the morning your assessment. You got to do it again. And he has shown us photographs in his lecture. A class 1A malampatti becomes class 3 or even 4. So remember this take-home message from the boss himself, that you got to do your limon or your malampatti on table again, because God forbid it has changed. After labor, she's gone into distress and now she has come for section. The whole scenario has changed. How many minutes I have? I think I'll finish. Yeah. So malampatti. Now, second take-home message which I want you all to understand is, don't rely only on malampatti. Yes, malampatti is good, no question about it. But there are multivariate index, so don't rely only on one. What is the next one? Thyromental distance. Now, these 244 cases were non-pregnant. That's why I put it in a different font and different color. They were non-pregnant patients, but the specificity and sensitivity was very high. So if you add one more factor into your PAC becomes far more accurate. So add thyromental distance also to your PAC of a difficult airway, and it becomes more potent. That is message number 2. You want to see how much? See, 2, 3, 4 malampatti give you 3, 7, 11% relative risk. But the moment the patient has short neck, it adds another 5% to it. Receding mandible adds another 9% to it. Protruding maxillary incisors add another 8%. If you have all these things in your patient, or the total will be 35%. So 35% chance that you will have a difficult. So my idea is to tell you this, that don't rely on one. There is a multivariate index which will come in the next slide. Start following that. Don't rely only on malampatti, but also do the multivariate index which comes now. That is the multivariate index. 7 factors: mouth opening, thyromental distance, neck movement, mandibular protrusion, body weight, malampatti classification, and the history of previous difficult intubation. All these 7 factors will give you a good idea that what has happened in the last time and what you are going to prevent the next time. Okay? It's far superior. So this upper bite test, ask them to do this. Can you bite your upper lip? Yes, you can. Most of you can, I can see from here. So there is no problem with any one of you. There is no difficult airway. I mean, one look and I know there is no difficult airway here at this moment. I keep watching people, not women. I do watch women, but in a different thing. That's like I used to travel by train when I was doing a residency. I used to say, God, if she comes on my table, I'm dead. 140 kilos and all, I don't want them. But as the luck would have it, Sandeep knows we do a lot of obesity together, so they do come up on our table only. So that's the multivariate index you must remember. So don't rely on one point, do many points. Now, another problem, age, obesity and higher malampatti scores. The problem is with age. The other day I told you I did a 140 kilo patient, and I mentioned this to another gynaec. She's telling me, I have got another 47 year, 140 kg waiting. I said, 47? Who told her to get pregnant, man? So she said, IVF. I mean, this IVF is causing big problems to us. All of you are going to get later pregnancies, women who initially say, we are double income, no kids, we don't want kids. And suddenly then it dawns upon them to have children. And no, not once, twice, because वो ना अकेला उसको बहुत bore होता है, तो he was asking, so we decided. You could have decided when you were 20, no? So this is another problem which we are also going to face. Our country is facing obesity and delayed pregnancies because of IVF and over-preservation. So this is again receding chin, upper bite test, obesity, high BMI, snoring, atlanto-occipital. I'll go a little fast because otherwise it gets repetition. These are various tests by which you can say and judge whether your patient needs this. This is atlanto-occipital joint, movement, if it reduces by 12%, they say angle, then 12 degrees rather, 33%, 12 degrees, the airway is difficult. Thyromental distance, I already told you, 6.5 is the normal. If it goes down, you got to be little careful. The next one is, of course, I told you upper bite list. If they can't do it, again, it becomes a problem. And morbid obesity, I've told you, more than 140 kilos, that's about 300 pounds. This is again a big, big, big problem. Preeclampsia. Now that is another big issue. These guys have a recipe for disaster written on them. Just see, they retain extravascular fluid. They have low oncotic pressure. So they have fluid, the tissues can't be felt. Their spines, when you are giving spinal, it just goes as if your finger is going into butter. The needle walks in as if you don't know you're pushing it into water. No resistance at all. They have excessive fluid overloads, edema, tissues are not felt, difficult backs. On top of it, they have thrombocytopenia. So your repeated intubations are going to cause edema. And a class 1 malampatti will become class 4, and soon after 3 attempts, you will not be able to intubate such patients. So God forbid, if you are going to give GA, prepare them well. You know Rantac, Perinom, MSET, your PPIs, your Pantoprazole, give it, please. You can do one more thing. If you are working in a good setup, keep that probe and see what are the contents, how much are the contents. So if you are very sure that aspiration nahi hoga, at least one tick you have that, okay, she will not die of aspiration at least when I am struggling for intubation. Everybody knows this, ramp position for an obese patient, ramp patient for an obese pregnant patient, definitely. Right? We all know what happens, the tragus becomes in the same line as sternum, intubation becomes easy. Pre-oxygenation, we've seen 3 minutes we keep, but the surgeon is there with his knife ready. He wants those extra 2 minutes. Ask the patient to take 8 deep breaths in 1 minute. It gives you exactly the same oxygenation. Message number 3, definitely 8 deep breaths in 1 minute. Somebody tried 30 seconds, 4 breaths. Not adequate, not adequate. So 8 deep breaths, 1 minute is good. Yeah, last kiti वेळ आहे? Last 5 minutes, na honar. Yeah. So 8 deep breaths, yeah, okay, great. Thrive. If you have it, please use it. Propped up position, ramp position, you are giving Thrive, humidified. I have attached it to my nose and I have seen, does it become uncomfortable? Not at all. You don't even realize that it is blasting 70 liters of oxygen into your nose. Beautiful, warm, humidified air goes in. Propped up position you give. It goes on, your oxygenation will not drop. You can aram se intubate. Yes, CO2 will increase, but remember, hypoxia kills. CO2 doesn't kill you. So even if PCO2 goes to 70, it's okay. You will hyperventilate and you will bring it down. But if oxygen goes to 70, your oxygenation needs to be checked. So Thrive, this is the cart I was telling you. If you don't have it, please make it. We're widely available, multiple drawers. You fill these drawers with whatever you can think of. As far as it is nicely organized, it's beautiful. You can have different laryngoscopes. Blades, your airways, your LMAs, everything can be there. And on the side, there's a space even for fiber optic if you have it. Okay, at one place, and especially the wheels are the most important thing. You can pull it from the ward to the OT to the labor room to the wherever you want to pull it to. Yeah, please have it. Video laryngoscopes, what can we say? But I intubate almost every patient on video laryngoscope. Every. Because unless you practice on normal patients, how are you going to suddenly in the middle of the night, you're going to try it on a 140-year who's not fasting? So, but as the literature says, 22, this is 22. 2 months back a paper came. They say we still are using very less video laryngoscope, 1.9%. So less than 2% people use video laryngoscopes in difficult airway situations. That's UK statistics, very bad. Coming to the algorithms, that is the management. Anticipated difficult airway, simple, don't read, don't give GA. End of the story. If you know it is an anticipated difficult airway, straight, only regional. Only regional, 3 attempts, 4 attempts, 5 attempts, I don't care. I am not. Surgeon, तू बाहर बैठ, कॉफी पी, चाय पी, वापस कॉफी पी, but मैं स्पाइनल ही देगा. और फेल होएगा तो वापस बिठा के भी स्पाइनल ही देगा. That is what it is. That is what this says. Okay, just do it. And if you are going to give GA, then try and do an awake. Prepare the airway and try and do awake and just see if you can. Go ahead and put in straight away. That's what the algorithm is all about. The other one is not so easy. This is the easiest one. That's why I made it into a little laughing matter. The other one gets very serious. This one is the most nasty. I still have 2-3 minutes because after this it's hardly extubation and that is it. Okay, so this one is the nasty one. Okay, you've decided to give GA and it was unanticipated. You put in a scope and you realize, boss, ये मेरे बस की बात नहीं है. Call the senior. Let him come. Don't keep doing unnecessarily. Same thing doing don't give you different results. पढ़ाई नहीं करेगा तो आदमी फेल ही होएगा. तो पढ़ाई करेगा तो ही पास होएगा ना. So do something differently. Then only your results are going to be different. Otherwise what? Same knowledge, same result. Change of position, calling for help, so many other things you can do. If oxygenation is there, you are still lucky. If the senior comes and puts in a tube, you are still lucky, go ahead with the case. If it doesn't happen, supraglottic airway. Twice. Again, if it doesn't happen, you are in for trouble. Try and maintain the oxygenation. If you can't still, then if your LMA also goes, still you have to think, can I do this surgery on LMA? Because if she vomits, I am not protected. Am I going to put in a bougie and take out the LMA? Will I be able to ventilate? All these things are going into your mind. Can I wake her up and give spinal again with some senior around, like Tempesar or someone who's far senior, who will do this? Is it possible? Think and think. And then again, if your LMA also is not going, you are heading towards CICO, call for as much help. God, if you have an ENT surgeon or someone who knows how to do a cricothyrotomy, get it done and move on. Otherwise, you are in for trouble. So that is the unanticipated difficult. That's the most nasty one. But, chalo, ho gaya, whatever. You've done it. I come back to the extubation part of it. This is the last part. In next one or two slides, I'm done. She wrote this. I have met this lady, extremely lovable and very well respected lady. I think I met her in Washington or somewhere. Jill Meyer. Classic paper she came out with, 1985 to 2003. She was doing the study and she realized that patients were dying not in intubation, but they were dying in extubation. That means either we were doing something wrong or we were extubating them earlier. No. We were extubating them and we were leaving the patient in the hands of the nurse in the recovery, and we were busy doing another case in another nursing home, and that is what our problem was. That's what she says. System errors played a role because there was no anesthetist present. For a difficult extubation, you got to cancel all your cases, let the money go, because what you are going to earn will go in one case that is filed on you. Far more you will lose. So stay there, cancel all your cases, be there in the recovery till the lady is finally fully, because the tube comes out, there is edema, slowly she hypoventilates, she's obese, nobody to look at, surgeon is busy in his OPD, and the patient goes for heavenly abode. Don't do it. Extubation is extremely important, and your difficult airway card should be there. You can take the patient back to the OT and do whatever you want, but don't fool around. And this is what she said. Lapses in post-op monitoring, inadequate supervision by an anesthesiologist. So the onus state is on us. Obesity was the biggest cause, along with Afro-American patients. Thankfully, we are not in America, so we don't get Afro-American patients. But obese patients, yes, we do get. So you got to be very, very careful while extubating. Got it? Another take-home message. So I am almost done. Some of the take-home messages I'll stay. It's a self-invited prophecy we saw. We've invited this trouble because we give lots of regionals. More common in obese. Obesity is also getting more common these days. Emergency LSCS, according to me, in an obese patient, in a roadside nursing home or any hospital which is not tertiary care where there is no help, according to me, is a recipe for disaster. You got to be very careful, choose your place and your surgeon. I would say that also is a take-home message. If you are working with lousy person, please don't work. Avoid, I am not available. Airway assessment is most, I am in Sangli. I am. Choose the place, that's what I said. Get trained help so you can train people. That's why you should have friends. In the middle of the night, I should have a friend who doesn't say, I'm in Kolhapur. So who comes with me, yeah? The difficult airway cart, I'm telling you, if you don't have it, I beg of you, please have it in your institute, wherever you are working. Keep the guidelines in the mind, and I recently spoke in Bala Venkat sir's conference about the situational awareness. Never lose situational awareness. I'll give one small example and I'll conclude. What is situational awareness? Is being aware where you are. There was a flight. Aviation industry, 34,000 feet pay, the flight was moving. As the airport started coming closer, the pilot started bringing it closer down. Suddenly, very close to the airport, they open the slats, in the sense your tire comes out for landing. And the faulty gear alarm started coming. Every crew was busy on that faulty alarm. And they didn't know, they didn't realize, they kept on encircling over the airport all the time, and finally the petrol got over and the flight crashed. So situational awareness is very important. Here there is difficult airway, yes, your tube is not going, but what is more important? Oxygenation. Blow some O's through that nose. That's what the Australian person who had come in Tata Cancer Hospital says. Blow some O's through the nose. So it is the hypoxia that kills. If you push oxygen, then there is no problem. Nasal prong, Thrive, whatever you have, use it and save the patient. Even if the tube doesn't go, it's okay. But focus on oxygenation. Thank you very much, ladies and gentlemen.
Thank you very much, Hemant, for this excellent presentation.
Questions we are going to take now or questions we are later?
We'll take it now.
Okay.
Now. Sir, I have never realized it. You needed it ever. But sir, if you have to, they say in the anticipated, sir, you can use it.
Yes, sir.
In unanticipated, middle of the night, again, how will you do? Because here the seconds are more important. Unless you are very trained, you are putting it, that is the only. In anticipated, yes, you can use awake. That's the guidelines also say. That if you have an anticipated, you straight away go in for awake intubation, fiber optic, or like that. But you have to prepare the airway for that. So that is a...
As we have short of time, only one more question, please.
Or I'm around, so you can always ask me.
Yeah.
First time only you have to wait. No, third time is to thankfully, this is all literature. If my spinal fails, I have straight away given GA because I work in most of the tertiary care institute where a lot of help is there. But for a person who's working in a nursing home setup, I have seen stories, heard stories that bupivacaine acted even after 20 minutes. Now here, do we have 20 minutes? The surgeon is ready with the knife. Fetal distress, can you wait for 20 minutes? In an elective section, you can wait of a difficult airway. But in an emergency section, no surgeon is going to wait for 20 minutes for your spinal to act. That is where the whole problem starts. You can't wait. You want to give, but he is not ready to wait. He or she, whosoever, the gynac, I mean to say, whosoever it is, they are not going to wait because there's baby. So now you have to have that balance. How much you can wait, max you can wait, and you can see what action has come, and then how do you, that inadequate action becomes, how are you going to do it? So GA becomes your only action, the definitive action to get out the baby fast. So that time you cannot wait in a difficult situation, in a laborious fetal distress. One more question and that's
Okay.
it. We'll call
No.
it a day. Okay.
Thank you, welcome.
No, I'll ask you.
Thank you very much. Actually, this difficult airway to define is very difficult also. One may find it is difficult, but another person may find it very easy. So it depends upon the person to person and patient to patient also. I remember one case having all things were normal, but patient having a long hairs, and she has style like Saira Bano. So I have to remove all these things, and then only I can intubate the patient. Second thing, we are losing our skills in intubation in the pregnant patient because of glottic airway also. And most important, that is basic, is back mask ventilation with 2 hands. In this obstetric and obese patient, we are also losing. And as Hemant correctly said, situation awareness is also important as a non-technical skill. And it should also, we have to make a leadership, decision making, communication, team working should be also most important factor. Thank you very much.
Lastly, say that you don't come across such a situation.
Yeah. Thank you.
Thank you so much, sir, for an interesting session. It was definitely an eye-opener. Dr. Hemant Shinde, sir, can we please have you on the stage? I now request Dr. Dilip Paranspe, sir, to please felicitate our speaker, Dr. Hemant Shinde, sir.
I request Dr. Mohan Patil sir to come on stage and felicitate the chairman and the co-chairman.
Paranspe sir is specially felicited. He is ex-president of MSA special.
This is our 75th Platinum Jubilee year. Also to mention, we are hosting a big conference in anesthesia for almost about 20 years now. So we take this opportunity to honor our past Maharashtra state presidents present here today. I request Dr. Hemant Shinde, sir, to please do the honor of felicitating Dr. Dilip Paranspe, sir. Dr. Dilip Paranspe, sir, practicing since more than 40 years, founder president SAFE Kolhapur, founder president ISCCM Kolhapur branch. It's our honor to have you, sir. Thank you so much. Thank you so much to all the dignitaries present on the stage for a wonderful session.